There is a single protein in your intestinal lining that your gastroenterologist, your internist, and your primary care physician almost certainly have never ordered a test for. Not because the test does not exist, not because the research is new. The research is 23 years old. The test has been commercially available for over a decade. And in study after study, elevated levels of this protein are found in patients with IBS, Crohn's disease, celiac disease, and autoimmune conditions (PAU). Patients who have been treated for those conditions, often for years, without the root cause ever being identified. The protein is called zonulin. And if your gut has not healed despite doing everything right (PAU), changing your diet, cutting out gluten, taking probiotics, following every protocol your doctor recommended (TAT), there is a good chance zonulin is the reason. Not the only reason, but the one reason almost nobody is looking for. In the next 26 minutes, I am going to walk you through 5 things. Promise 1, what zonulin actually does inside your intestinal lining, and why its specific mechanism explains why so many gut conditions resist treatment. Promise 2, the 7 clinical signs including 3 that almost no patient connects to gut health. Promise 3, the exact test name and test type you need to request from your doctor and what most labs measure wrong. Promise 4, the 4 categories of food, medication, and environmental trigger that drive zonulin up, and the specific one that elevates it in nearly every patient I see. And promise 5, the 3 intervention steps that have the strongest clinical evidence for bringing zonulin back into a healthy range, ranked by how fast they work. There is one thing about zonulin that surprised me the first time I read the research. I will come back to it after promise 2. Because it changes how you think about every gut symptom you have ever had. Here is exactly what I am going to walk you through. Promise 1 is the mechanism 2. What zonulin does to the tight junctions in your intestinal lining. Why a protein produced inside your own gut becomes the primary driver of intestinal permeability, and why blocking it is not as simple as taking a supplement. Promise 2 is the 7 clinical signs of elevated zonulin, including 3 that most patients never report to their gastroenterologist, because they do not know those symptoms belong in a gut conversation. Promise 3 is the specific test higher. Promise 3 is the specific test tell, the difference between serum zonulin and stool zonulin testing, which one the research actually supports, and the exact phrase to use with your doctor so you do not walk away with the wrong panel. Promise 4 is the 4 trigger categories, including the one that elevates zonulin in roughly 8 in 10 patients regardless of diet. And Promise 5 is the 3 interventions ranked by speed of effect have, the one that takes 4 days, the one that takes 3 weeks, and the one that takes 3 months but produces the most durable result. I am a gastroenterologist with a clinical focus on the gut-brain axis, specifically on intestinal permeability and functional gut disorders in patients who have already gone through the standard diagnostic pathway without resolution. My practice sees roughly 800 patients a year in that category. What that volume shows me, consistently, is patients who have the right diagnosis and the wrong target. I want to be transparent about something before we go further. The information in this video is for educational purposes only. It does not constitute medical advice. The patient stories I describe are composites, identifying details changed to protect privacy (PAU), representing patterns I have seen repeatedly in clinical practice. Before changing any supplement, dietary protocol, or requesting any lab panel, please consult your own physician. Dr. Rachel Torres is an AI-generated educational persona created to make complex gastroenterology research accessible. The content is reviewed for clinical accuracy, but your individual health decisions belong with your doctor. Let me tell you about a patient. I will call her Sandra. She was 47 years old, a registered nurse from outside of Houston. For 6 years, Sandra had been treated for IBS with constipation predominance. She had tried the low FODMAP diet twice. She had taken 2 different gut motility medications. She had done a colonoscopy, an upper endoscopy, and a hydrogen breath test. All of them normal, or close enough to normal that no intervention followed. What Sandra also had, which she did not mention to her gastroenterologist until her 3rd visit with me, was a rash on her forearms that her dermatologist had called contact dermatitis, recurring joint stiffness in her fingers that her rheumatologist had labeled early osteoarthritis, and what she described as a fog in her thinking that she had attributed to perimenopause. 3 specialists. No one had connected the dots. When I ordered a stool zonulin panel on Sandra's first visit, her zonulin was elevated at 240 nanograms per milliliter. The reference range is under 107. Her intestinal wall was not functioning as a barrier. It was functioning as a sieve. Here is what zonulin is and what it does. Zonulin is a protein, a BOF, technically a family of proteins, the dominant one being a pre-haptoglobin 2 fragment tau that regulates the tight junctions between the epithelial cells lining your small intestine. Think of the tight junctions as the door locks of your gut wall. When those locks are functioning, only fully digested nutrients pass through into your bloodstream: amino acids, simple sugars, fatty acids. When those locks are open, larger molecules pass through that are not supposed to. Partially digested food proteins, bacterial fragments called lipopolysaccharides, and even live bacterial cells in severe cases. Zonulin is the molecule that opens and closes those locks. It is not a foreign invader. It is produced by your own intestinal cells and your own liver. In a healthy gut, it opens the locks briefly during digestion and closes them again. The problem occurs when something triggers your gut to overproduce zonulin, keeping the tight junctions chronically open. When that happens, your immune system, which lines the gut wall on the other side, begins responding to everything that passes through. And an immune system responding to everything looks, from the outside, like a list of unrelated conditions. A rash, joint inflammation, brain fog, bloating, constipation, fatigue. This is why zonulin explains what standard gut testing misses. A colonoscopy looks at the structural integrity of the colon. It does not measure tight junction function. An endoscopy looks at the mucosa of the stomach and duodenum. It does not measure the permeability of the epithelial layer. A hydrogen breath test measures bacterial fermentation. It does not measure what those bacteria are doing to your gut wall. A pediatric gastroenterologist at Harvard Medical School who first identified the protein's role in intestinal permeability in 2001. His initial work was on celiac disease. He found that gliadin, the protein component of gluten, triggered zonulin release even in people without celiac disease. That finding was published, it was replicated. It then sat largely outside mainstream clinical practice for the better part of 2 decades. Here is what surprised me the first time I read Fasano's research canned, and what I said I would come back to. Zonulin is not only produced in the gut, it is also produced in the blood-brain barrier. The same tight junction mechanism that governs intestinal permeability governs neurological permeability. When gut zonulin is chronically elevated, blood-brain barrier zonulin often follows, which is why the brain fog, the mood disruption, the cognitive slowdown that so many gut patients report is not psychosomatic. It is a second-order consequence of the same protein dysregulation. Sandra's fog was not perimenopause. It was a barrier problem that started in her intestine and extended to her brain. The mechanism works in 3 phases, and understanding all 3 is what separates a treatment that lasts. Something causes your intestinal epithelial cells, the cells lining the wall of your small intestine to produce excess zonulin. The 4 main trigger categories are the ones I will cover in Promise 4. For now, the important point is that the trigger is not the disease. The trigger is upstream of the disease. Most gut treatment protocols target the disease, tau, the inflammation, the dysbiosis, the motility problem. The trigger continues operating. The zonulin continues being overproduced. The tight junctions stay open. The treatment suppresses symptoms without addressing the mechanism. Phase 2 is the cascade. Once tight junctions are chronically open, the immune layer beneath the epithelium pota, specifically the lamina propria, which is dense with macrophages, dendritic cells, and T lymphocytes, begins responding to the increased molecular traffic. Lipopolysaccharides from gram-negative bacteria are particularly activating to this immune layer. LPS binds to toll-like receptor 4 on macrophage surfaces and triggers the release of pro-inflammatory cytokines, primarily interleukin-6, interleukin-1 beta, and tumor necrosis factor alpha. These cytokines are not contained to the gut. They enter systemic circulation, they drive inflammation in joints, they cross a compromised blood-brain barrier. They disrupt thyroid signaling. They contribute to insulin resistance in liver cells. This is the part of the mechanism that explains the seemingly unrelated symptom cluster in patients like Sandra. The inflammation is not in multiple organs independently. It is sourced in the gut and distributed systemically. The joint pain and the brain fog and the thyroid disruption are downstream symptoms of a single upstream mechanism. Phase 3 is the feedback loop. Systemic inflammation itself further compromises the gut barrier. Inflammatory cytokines directly increase zonulin production in intestinal cells. So elevated zonulin produces inflammation, and inflammation produces more zonulin. This is why many patients plateau on gut protocols. They reduce triggers enough to reduce inflammation slightly, but not enough to break the feedback loop. Zonulin stays elevated at a sub-peak level. The barrier stays compromised. Symptoms improve 30 or 40% and then stabilize. What breaks the feedback loop is not suppressing inflammation with medication, though that has its place. What breaks the feedback loop is reducing zonulin directly, which requires two things: identifying the active triggers and supporting tight junction repair simultaneously. Those are the interventions in PROMISE 5. One additional piece of the mechanism that is relevant clinically: zonulin levels are not static. They fluctuate within a 24-hour period depending on what you eat, what bacteria are active in your gut, and what your stress response is doing at any given moment. This is why testing matters. A single blood draw measuring serum zonulin is not sufficient. Stool zonulin, averaged over the transit time of a sample, gives a more accurate picture of what your gut is doing chronically. I will explain the test distinction in PROMISE 3. The 7 clinical signs I look for when zonulin is elevated are not all gastrointestinal, and the ones that are not gastrointestinal, this is the most common presentation. Patients have tried low FODMAP, low histamine, elimination diets. This is what nobody tells you, which means the gut-based source never gets addressed. Sign 1, chronic bloating that does not resolve with dietary changes. They improve during the restriction and relapse when they reintroduce. The bloating is not caused by specific foods. The bloating is not caused by specific foods. It is caused by the immune activation triggered by the open-tight junctions. Any food that stimulates gut immune activity will produce bloating when zonulin is elevated. Sign 2, a pattern of food sensitivities that grows over time. Early on, a patient avoids 2 or 3 foods that reliably cause symptoms. Over months or years, the list expands. This is a hallmark of elevated zonulin TOR. As more molecules pass through the gut wall uncontrolled, the immune system builds reactive responses to more of them. The sensitivity list grows not because the foods are becoming more problematic, but because the barrier is becoming more permeable. Sign 3, fatigue that is disproportionate to sleep and activity level. This is a cytokine effect. Interleukin-6, produced by gut wall immune activation, directly suppresses mitochondrial function in muscle cells. Patients describe a tiredness that sleep does not resolve, sometimes called non-restorative sleep, sometimes called post-exertional malaise. It is routinely attributed to depression, to thyroid dysfunction, to low iron, to PTO, all of which can be complicating factors but the primary driver when zonulin is elevated is systemic inflammatory cytokine load. Sign 4, that is not proportionate to life circumstances. I want to pause on this one. Because of all the signs, this is the one that most consistently gets misattributed a HAPT, and the misattribution has real consequences. I had a patient I will call Marcus. He was 52. He had been on a low-dose SSRI for 18 months for what his psychiatrist described as generalized anxiety. The anxiety was real. The SSRI helped partially, but Marcus also had bloating, irregular bowel habits, and a growing list of foods that seemed to trigger what he called a crash, a 24-hour period of fatigue and irritability after eating certain meals. His psychiatrist and his gastroenterologist had never spoken to each other. When his zonulin came back at 191 nanograms per milliliter, and we addressed the permeability, his anxiety scores dropped by 40% over 3 months after, without changing his psychiatric medication. The mechanism is the blood-brain barrier consequence I described earlier. LPS crossing a compromised barrier activates neuroinflammation. Neuroinflammation disrupts serotonin synthesis. Approximately 90% of serotonin is produced in the gut-brain axis, and that synthesis is disrupted by chronic gut inflammation. Sign 5, skin changes without clear dermatological cause. Rosacea, eczema flares, unexplained hives, and the type of reactive skin Sandra presented with are each associated in the literature with elevated zonulin. The skin is a secondary immune organ. When systemic inflammatory load is high, the skin reflects it. Dermatologists treat the skin. The source is the gut. Sign 6, joint stiffness or pain without a degenerative cause on imaging. This is the rheumatological signal. LPS-driven systemic inflammation preferentially targets joint synovium. Patients in their 40s and 50s are frequently diagnosed with early osteoarthritis or undifferentiated arthralgia. When zonulin-driven permeability is the actual driver, treating the inflammation without addressing the source produces temporary improvement. Sign 7, an autoimmune diagnosis within the past 5 years or a family history of autoimmunity. This is what nobody tells you. Fasano's research established zonulin-driven intestinal permeability as a necessary precondition, not the only condition, but a necessary one, for the development of autoimmunity in genetically susceptible individuals. The sequence is elevated zonulin, open tight junctions, immune exposure to gut contents, molecular mimicry between gut proteins and self-tissues, autoimmune activation. Hashimoto's thyroiditis, rheumatoid arthritis, type 1 diabetes, multiple sclerosis pol, all have been associated with elevated zonulin in research. Treating the autoimmune condition without addressing the permeability does not stop the underlying process. If you recognize 3 or more of these signs through in yourself or in someone in your family TOF, type the word barrier in the comments. Type the word barrier in the comments. I read every reply. And the pattern I am describing is more common than any of my colleagues in general practice currently recognize. Here is what to do. 5 specific steps, in the order I would implement them if you were sitting across from me in my office. Serum testing that measuring zonulin in blood pate has a significant false negative problem because zonulin in serum is partly bound to carrier proteins that obscure the measurement. Stool zonulin measures the protein as it is secreted into the gut lumen, which is the more clinically accurate representation of tight junction activity. Step 1, get the right test. Ask your doctor for a stool zonulin test, not a serum zonulin test. The specific test is a stool ELISA panel for zonulin and occludin. Occludin is a second tight junction protein, and its presence in stool, like zonulin, indicates tight junction breakdown. Some labs report them together. The reference range for stool zonulin is typically under 107 nanograms per milliliter. Anything above that warrants investigation of the trigger categories. If your doctor is unfamiliar with stool zonulin testing, the labs that offer it as a standalone panel include specialty functional medicine labs. And your doctor can order them as an out-of-pocket panel or, in some cases, as part of a comprehensive stool analysis. The name of the test to request is Intestinal Permeability Assessment Stool Panel. That exact phrase is recognized at most major specialty labs. Step 2, identify your active trigger category. The 4 trigger categories for zonulin overproduction, ranked by prevalence in my patient population, are as follows. Category 1 is gliadin exposure, the protein fraction in wheat, rye, and barley. Fasano's research established that gliadin triggers zonulin release even in the absence of celiac disease. This is not an argument to eliminate gluten permanently. It is an argument to eliminate it during the active healing phase and reassess after 3 months. In roughly 7 in 10 patients I see who carry elevated zonulin, reducing gliadin exposure produces measurable reduction in zonulin within 3 to 4 weeks. Category 2 is small intestinal bacterial overgrowth, commonly called SIBO. Overgrowth of gram-negative bacteria in the small intestine means chronically elevated LPS in direct contact with the intestinal wall, which drives both immune activation and zonulin production. A hydrogen methane breath test diagnoses SIBO. If SIBO is active, treating it is part of the zonulin protocol, not a separate issue. Category 3 is chronic psychological stress. This is the one that surprises most patients. Cortisol and corticotropin-releasing hormone directly stimulate zonulin secretion in intestinal epithelial cells. This is a documented pathway, not a clinical intuition. Patients who manage every dietary trigger but not their stress response, you'll see partial zonulin reduction and plateau. The mechanism is not psychological, it is biochemical. CRH is a direct agonist at the zonulin-producing pathway. Category 4 is non-steroidal anti-inflammatory drug use, commonly called NSAIDs PAW, ibuprofen, naproxen, aspirin at therapeutic doses. NSAIDs inhibit cyclooxygenase enzymes that are necessary for maintaining the mucus layer overlying the intestinal epithelium. When the mucus layer thins, epithelial cells are more directly exposed to luminal content, and zonulin production increases. Patients with chronic joint pain who use NSAIDs regularly are often caught in a cycle. Gut permeability drives joint inflammation, Joint inflammation drives NSAID use. NSAID use drives more gut permeability. Step 3. Repair the tight junctions. The intervention with the fastest onset, measurable in 4 to 7 days in most patients born, is L-glutamine supplementation. L-glutamine is the primary metabolic fuel for intestinal epithelial cells. At doses of 5 to 10 grams per day, divided across 2 or 3 doses, it directly supports tight junction protein synthesis. The research on L-glutamine and intestinal permeability is consistent across multiple randomized controlled trials. It does not require a prescription. It is available as a powder, which is the form I recommend because it allows dose titration. Please discuss dosing with your physician before starting any supplementation protocol. The second intervention, with effects measurable in 2 to 3 weeks, is targeted probiotic support, specifically strains with documented evidence for tight junction upregulation. Not all probiotics do this. The strains with the most consistent research are Lactobacillus rhamnosus GG, Lactobacillus plantarum, and Bifidobacterium longum. These strains produce short-chain fatty acids and directly upregulate the expression of claudin and occludin, the structural proteins of tight junctions. Multi-strain products that combine all three are available commercially. The dose that appears in the clinical literature is typically a minimum of 10 billion CFU per day. The third intervention, which produces the most durable result over 3 months, is mucosal barrier support through zinc carnosine. Zinc carnosine is a chelated compound, zinc bound to the amino acid carnosine, that has been shown in peer-reviewed trials to accelerate mucosal healing, reduce intestinal permeability markers, and reduce zonulin specifically. The trials use doses of 75 milligrams twice daily. It is slower than L-glutamine, but it addresses a deeper layer of the barrier, the mucus and glycocalyx layer, not just the tight junctions. Used alongside L-glutamine, it addresses both layers simultaneously. Here is something almost no patient is told, and almost no standard gut protocol includes. Zonulin is bidirectional. Your gut produces it downward into the gut lumen and upward into the bloodstream. Most of the research and most of the clinical attention focuses on what zonulin does to the intestinal wall going outward. But Fasano's more recent research has examined what happens to the blood-brain barrier fan, and specifically to the vagus nerve pathway akjan, when serum zonulin is chronically elevated. The vagus nerve runs directly from the brainstem to the gut wall. It is the primary communication pathway of the gut-brain axis. When zonulin disrupts the tight junctions of the gut wall, the local inflammatory environment around the vagal terminals in the gut changes. Vagal tone, the parasympathetic signal the vagus carries jod, is impaired, and reduced vagal tone is associated with impaired gut motility, impaired gastric acid production, and impaired immune regulation in the gut itself. This means there is a neurological loop inside the zonulin problem that is independent of the immune cascade. It is a vagal loop. And the intervention that addresses it, deliberately toe, is vagal nerve stimulation, specifically diaphragmatic breathing at a rate of 5 to 6 breaths per minute, practiced for 10 minutes per day. This rate of breathing is the resonance frequency of the vagal reflex arc. It is documented to increase vagal tone, reduce systemic inflammation, and support gut motility in patients with IBS. Combined with the 3 interventions above, it addresses all 4 layers of the problem: the tight junctions, the mucosal barrier, the microbial environment, and the neural regulation of the gut wall. I have not seen this specific combination discussed in any mainstream gut health protocol currently in circulation. I have put together a free guide called the Gut Barrier Reset Protocol. It includes the exact test panel request language to use with your doctor, a printed card you can bring to your appointment. It includes a 4-week implementation schedule for L-glutamine, the probiotic strains, and zinc carnosine with dosing, timing, and sourcing. It includes a 1-page trigger identification checklist that maps the 7 clinical signs to the 4 trigger categories, so you can identify your highest probability trigger before your first test result comes back. And it includes the specific breathing protocol for vagal tone pile, the 5 breath per minute exercise, with a guided timer sheet you can use at home. The guide is free. There is a link in the description below this video. It is also in the pinned comment. Type the word protocol in the comments if you would like me to send it to you directly. I check those replies and I send the link manually to everyone who asks. If you want to know the exact state of your gut microbiome before starting any protocol, not just zonulin, but the full picture of bacterial diversity, overgrowth markers, and digestive enzyme function, The tool I use and recommend to patients who want to run their own baseline is the Viomi Gut Intelligence Test. It is an at-home stool test. The results come back as a personalized food and supplement report. The link is in the description. I am affiliated with Viome, which means if you use my link, a portion of the purchase supports this channel at no additional cost to you. Full disclosure, as always, I only recommend it because it is what I actually use. If you take nothing else from this video, take this. Your gut has a mechanism. That mechanism has a name, Zonulin. And the reason it has not healed despite the diets and the supplements and the protocols is most likely not that those approaches were wrong. It is that they were applied downstream of the problem. You cannot consistently repair a wall while the trigger that keeps opening it is still active. The 4-layer approach I described drove L-glutamine to repair the tight junctions, targeted probiotics to rebuild the mucosal microbiome, zinc carnosine to restore the barrier layer, and diaphragmatic breathing to restore vagal tone pod, addresses the mechanism at all 4 levels simultaneously. Not one of them is experimental. All of them have peer-reviewed trial data behind them. None of them require a prescription. And all of them work better together than any one of them works alone. What is required is a test. Because without knowing your zonulin level, you do not know whether this mechanism is active in your case. The test is the starting point. Everything else follows from that number. If this video gave you a framework you did not have before, please hit the like button. It tells the algorithm that detailed mechanism-level content is what this audience needs more of. Subscribe to the channel if you are not already. The next video covers the gut-brain axis at the level of the vagus nerve, or specifically the one signaling pathway that connects chronic gut inflammation to chronic anxiety, and what the most recent clinical trials say about reversing it. That is coming next. Your gut is not just a digestive organ. It is the headquarters of your health. Treat it like one. If you have a friend, a family member, or a colleague who has been struggling with gut symptoms for more than a year, who has had the standard tests, followed the standard advice, and is still not getting better, but send them this video. What I described today is the explanation most gastroenterologists are not offering yet. It may be the piece they have been missing.